So it's really a pleasure to be here, and I'll try to attack this rather complicated topic by introducing some systems that we have available for circulatory support, and to give you an idea as to what really happens to your patient when you send them from a non-quaternary center to one of our centers, and when they receive some sort of a mechanical circulatory support. I'm also going to touch on the some of the indications and the device selection, and really go over what is available out there for us to treat advanced cardiogenic shock or acute heart failure. All right, so here's the quick outline. Like I said, I'll talk about mechanical circulatory support. We'll touch on indications that touch more. We'll talk about the timing of intervention, patient selection, and I will outline briefly what's out there, what's available, and how to use it. This is my only conflict of interest. So as we talked about earlier, the indications for mechanical circulatory support are really plethoric and very, very complex. And at the end of the day, it probably boils down to the gut feeling of the clinician who's taking care of this patient. So, you know, the old-time kind of mythical definitions of cardiogenic or persistent cardiogenic shock, refractory cardiogenic shock with cardiac indices less than 2.2 liters per minute per meter square, with the blood pressure, the capillary wedge pressure, the early onset of multi-organ failure, have probably become, over the last couple of decades, quite archaic, and especially in the context of early revascularization and whatnot. So we need to really define a clear set of criteria as to when to initiate the next level of support. And this is extremely difficult. I think among the clinicians, when somebody mentions the term mechanical circulatory support, the patient should probably end up on it, provided that the idea of initiating on that particular patient is reasonable from the point of view of the patient. We know very well, and we have known for many years, even from the early Abiomed BVS 5000 registry, which is one of our early cardiac support devices, is that the initiation of mechanical circulatory support early is paramount in terms of the survival of the patients, where the mortality was cut to a third when compared to those who have had mechanical circulatory support initiated beyond the 6-hour point mark. We know that if you delay the institution of mechanical circulatory support, that you're more likely to end up on a biventricular support system rather than a univentricular support system. And if we wait for cardiac arrest, we're probably reducing the chance of survival to less than 1 in 10 compared to about 1 in 2 when we initiate very early. So, like I said, patient selection becomes paramount. You have to decide whether your patient is a candidate for mechanical circulatory support by predicting the next step. So what is the plan of the game for that particular patient? Am I going to support somebody with a mechanical circulatory support if I know that the following step in this patient's social, medical, whatever course of or whatever dimension is unacceptable? The patient is not a transplant candidate. Patient is not a durable mechanical circulatory device candidate. What do I do with each particular patient? We have to be aware of major complications, and I will not dwell on renal, pulmonary, and so on, but I will dwell on the right ventricular failure. This is what gets us, and this is what gets us in terms of selecting our patients. We have to understand that the right ventricular failure, or right ventricular limitation is probably a better term, is extremely common in our patient population. The patients who come with left ventricular failure probably have an element of right ventricular limitation that goes under-recognized initially at the beginning. The patients who have non-ischemic heart disease and who present in shock are more likely to require biventricular support devices as opposed to univentricular. The optimization of RV function itself has been one of the paramount stones in terms of managing these patients. And the recognition of early RV limitation is one of the most important parts of caring for these patients. So I will go briefly over what's available out there, and everybody knows about the aortic balloon pump. It's been around since the late 60s. It is thought to augment ventricular performance and somewhat increase the cardiac output by increasing diastolic blood flow. I'm not really sure that this idea of augmentation of the cardiac output is actually valid, especially in patients who have undergone revascularization. Currently, we're conducting a study looking at the cardiac output measured by a Swan-Ganz catheter in patients who have had balloon pumps implanted after coronary revascularization has been completed, either by, in our population, mainly surgically. And what we have found so far that balloon pump, in terms of augmenting cardiac output, is probably as good as bloodletting. The SHOCK AIBP trial has also looked at randomization of 600 patients who have undergone coronary intervention and have found no difference in 30-day mortality, the length of stay of the hospital, serum lactate, and similar parameters among the patients who have and who haven't received the balloon pump. Sort of I think the cornerstone of circulatory support in around the world today is the so-called ECMO, which is extracorporeal membrane oxygenation. And this has been around, and it's been an extension of cardiopulmonary bypass, which is utilized on a daily basis in cardiac surgery. And it has really gained, or it had gained popularity in the pediatric population as both a recovery system, or a circulation recovery system, or a lung recovery system, as well as a bridge to a univentricular device or transplantation of the heart and or lung. So we all know what extracorporeal life support is all about. There's a drainage from the venous system and the liver into the arterial system. There is some reduction in the LV preload. However, what we need to keep in mind is that in cases of non-central delivery of ECLS, meaning through usually through femoral vessels, we have a significant afterload introduction to the system, and in particular when the patient is failing from the cardiac point of view, we have to use this with a lot of caution. There is an issue of LV distension. There is an issue of other complications with ECMO, and we need to look back and assess the data that is out there and determine in which patient population this is appropriate. What I hope you get out of this talk is that we need to select the correct therapeutic device for a correct pathophysiologic process. The other thing is that we need to recognize that what I'm presenting, these devices that we have currently, these are not salvage devices, these are therapeutic devices, that we need to consider them in our therapeutic armamentarium early, like we do everything else. There's very good data coming out of University of Michigan, where I trained, where Dr. Bartlett's group looked at 1,000 patients who were supported with ECMO, and this in particular is VV ECMO, but the important part is the complication rate and whatnot, which in centers that do significant volumes becomes very, very low. This is a simple setup of an ECMO system through it is a VA system for circulatory support with a femoral cannulation. This is a maquette device from what I see, or something, or perhaps a Centromag device, but this is sort of the standard today. So what we have to understand about ECMO is that there's no myocardial unloading, there's no ventricular offloading. ECMO is not a heart support. ECMO is probably one of the worst things you can give to a failing left ventricle. We introduced the afterload to a ventricle that's not dealing with its volume, that is trying to recover, that requires low end-diastolic filling pressures, low end-diastolic filling volumes, and we need to vent if we need to vent. We also have to think about Harlequin syndrome. We have to think about coronary Harlequin syndrome. This is usually a subclinical phenomenon, but in a heart that's trying to recover and regenerate ATP, regenerate myocytes, this could be a very, very important issue. Some of the circuit management and whatnot can be difficult. We can have bleeding complications at the sites, hemolysis, et cetera, and in majority of the centers in Canada today, this is resource intensive because we require a perfusionist at the bedside, and this can last for many, many days. So what we really need to do is we need to provide full hemodynamic support. We need to offload the ventricles if we can offload the ventricle. We have to avoid ECMO if the only issue is isolated univentricular failure or biventricular failure where the lungs are okay. Now, this, of course, comes with the proviso that the devices have to be available. We need to find a device or devices that permits myocardial and end organ recovery, that provide good flow, that are easy to implant and explant, and that are efficient and cost-effective. So, in keeping with this, the most recent set of guidelines regarding short-term mechanical and especially percutaneous mechanical circulatory support actually endorses the use of these devices in many, many clinical situations, from complications of acute MI to acute allograft rejections to post-transplant RV failure, LV failure, etc. Even in some of the patients who are septic and have elements of septic shock, devices have been used. This allows us to minimize pressors, to improve oxygenation, to decrease myocardial oxygen demand, and to improve perfusion substantially. One of the devices currently available is the Tandem Heart PVAD, which has now gone through multiple generations of improvement and is becoming a really, really good device. All of these devices that I'm going to present basically rely on the same principle, and that is some element of a bypass of a particular chamber in question. So whether it's the right ventricle or the left ventricle, the ventricle of interest is somehow offloaded or unloaded, and the blood from that particular ventricle is delivered into the arterial system via an alternate route. This alternate route can or may not include an oxygenator and provide additional oxygenation. So all of these devices, including Tandem, is implanted percutaneously. This particular device has a cannula that traverses the atrial septum and offloads the LA, hence reducing the preload on the LV, hence reducing the myocardial consumption, myocardial oxygen consumption, and allowing flows probably between 3 and 5 liters or something like that. As mentioned by the previous speakers, the randomized controlled trials that have looked at comparing these devices to placebo or to another device have not really been promising in terms of the outcomes. However, it is the placement, the timing of the placement of these devices that challenges the quality of the data and the design of these trials. Currently emerging and very popular device is the Tandem Heart's Protect Duo, which is a right ventricular bypass devices. So it's delivered either through the upper venous circulation or the lowest venous circulation. It allows for bypassing of the right ventricle with delivery of blood directly from the RA to the pulmonary artery. This can have an oxygenator incorporated in it and can serve as both an RVAD as well as an ECMO system. So this is a recently published paper that I stole this from, where they have added the Protect Duo as a treatment modality for RV failure after an LVAD implantation. Another device is an Impella system. This is produced by Abiomed. Impella currently has 3 platforms and 3 sizes. This is a left ventricular bypass devices. So the device itself is positioned across the aortic valve. Depending on its size, it can be delivered percutaneously or via a surgical cut down on whatever vessel, femoral, subclavian artery, or directly into the aorta. The device allows for offloading of the left ventricle. It allows for cardiac output, for flows anywhere between 2.5 and 5 liters. And it is very successful in terms of the offloading the left ventricle and decreasing myocardial oxygen consumption and allowing for recovery of the ventricle itself. Again, another prospective trial versus AIBP, which really didn't demonstrate much more than we expected with the Tandem Heart. There's a new device that's coming out on the Canadian market soon, which is the right-sided, the Impella RP, similar concept to the Tandem Protect Duo without a possibility to introduce an oxygenator. It's essentially a right ventricular bypass system that allows up to 4 liters per minute of flow. There's a trial that's undergoing right now, or has completed, the Recover Right, which looked at the safety and efficacy and survival at 30 days or to discharge of these patients, and showed significant improvement. We have some of the old extracorporeal systems, meaning old designs but significantly improved technology. Centromag Levitronics VADs are probably what is generally accepted nowadays as sort of a short to medium term devices. These are extracorporeal. The design is focused on the levitating magnetic type of design, where the avoidance of contact of blood with the surfaces is emphasized, so that the elements of hemolysis and blood destruction, blood component destruction, are lowered. The principle is simple. Usually there is some sort of there's a ventricular bypass system. The blood is drained from, if this is the left ventricular side, from somewhere in the left ventricle or the left atrium, and it's delivered into the arterial system, most certainly in this case into the aorta. It is very similar if it's used on the right side, where the blood is delivered, sucked out of the right ventricle and delivered into the PA. We have to decide for each one of our patients whether what's the appropriate device, whether ECMO is indeed the optimal device, whether the patient needs a complete or partial circulatory support. With the availability of some of the percutaneous devices that deliver a limited flow, such as Impella 2.5 or Impella CP, which flows up to 4 liters, we have to decide whether that is adequate for our patients. And the important part is that initially it might be. However, when and if the signs of multi-organ failure kick in and the patient starts to vasodilate, we have to reassess and determine whether what we thought initially was an adequate flow for our patient is an adequate flow at that point in time. So here's a bit of an algorithm that I try to follow when I manage these patients. So I want to emphasize that the isolated primary right ventricular dysfunction is exceedingly rare. Our cardiology colleagues know that the isolated right ventricular infarcts are rare. Hence, the need for isolated right ventricular assist device is rare. Be especially aware of the quote-unquote a normal or a mildly dysfunctional left ventricle when you're dealing with a patient who comes in with a significant right ventricular failure. Because generally we have to assess what the left ventricle would look like if it received a full load from the right ventricle. If you have a patient who has an LVEF of 35, 40, 45% with a blown dysfunctional RV, you have to think in your mind whether this patient truly has a univentricular dysfunction or biventricular dysfunction. We also have to be very aware of the patients who come in, as I mentioned, and who require maybe 2-3 liters of additional flow, but then they vasodilate and then they require more and more flow, and we have a major device limitation in terms of supporting them. So if you put a patient on an Impella 2.5 and let them sit, and overnight they're given volume and volume and volume, simply because we're not achieving adequate perfusion pressures and adequate flow, we have to reevaluate whether we need the patient to undergo a revision of the device to something that provides more flow. It is extremely rare that a patient who is not in cardiac arrest, who presents in ventricular failure of either left or right or both, who doesn't have a lung problem other than pulmonary edema, that this patient will end up in ECMO. As I said, we have to keep in mind that the primary reason for these pathologies is a ventricular limitation and not a circulatory collapse. Once again, ECMO is a circulatory support. It is not a heart support. So we have to govern our therapy towards the goal of providing adequate flow and organ perfusion, and to reestablishing and reevaluating whether the current support device is adequate. And this we will have to do at whatever periods of 1 hour, 2 hours, 10 minutes if necessary, by the strategies that have been previously identified. We have to avoid complications, and evaluate devices for malposition and hemolysis frequently with use of both Swan-Ganses, echocardiography, and whatever else is available to us. Thank you very much.
Great.